Hello, everyone, and welcome back to the second season of our show, The Rest Isn't Orthopaedics, hosted by myself, Rayhan, and Prof. Johansson, who's joined with me today.
Hello, everybody.
And during our first season, we were able to cover most of the key topics with regards to the multidisciplinary care of older patients or older people, viewed through the lens of hip fracture. But we decided there are a few more topics we wanted to delve a bit deeper into. And today we're going to talk about pain and what happens if someone falls over and comes into hospital with their hip fracture. So, Prof. Johansson, if Grace has fallen over and has been admitted into hospital, what are we going to help to do to manage her pain?
Yeah, so pain is one of the three topics that we touched on in our second podcast as the three physiological stresses on her when she has a hip fracture and the three reasons why she might unravel. She's bleeding into her hip, she's now immobile and going to run into problems because of that, but she's in pain and frightened because she's in pain. And the mixture between fear and pain is really important for us to try and tackle. So what did they teach you about pain management at medical school?
Well, I know we've got our WHO ladder and the multiple rungs that we can climb up. So starting at the bottom, we've got our paracetamol. Then climbing up, you've got weak opioids. And then finally at the top, you've got much stronger opioids like, I guess, morphine.
Yeah, I'm disappointed that that's what they're still teaching because that's really out of date now, certainly for the UK. Pain management is much more sophisticated than that. That used to be the introduction that I would get to pain management many years ago. And in many countries of the world where availability of morphine is quite limited, it's very relevant to think about the alternatives that might be available. But if you're going to use the pain ladder, you're going to ask Grace to climb a ladder with a broken leg. That seems a completely unreasonable thing to do to her.
Sounds quite difficult.
It's difficult, but it means that you're potentially saying, oh, she's got a bit of pain, let's give her some paracetamol and see how she goes, which is the implication of the WHO ladder. Oh, she's still in pain. Well, let's give her some codeine and see what happens. Oh, she's still in pain. We'd better give her some morphine. And that sort of makes sense, but it doesn't make sense to her. She's come in, she's in pain, and we've given her drugs that we know aren't going to be strong enough to deal with the pain that she's got. So she's got a broken leg. She needs strong opioids if she's going to be able to cope with that pain, or at least other strategies for managing her pain. We need to think about how we would set about doing that. The other thing that she's troubled with is a very orthopaedic type of pain, the sort of pain that people with arthritic joints get, the sort of pain that anybody with a fracture gets. It's not like the nagging pain that's constantly there if, for instance, you had a tumour or something like that. She's got what we call incident pain. It hurts to move the bit that's broken. And that's key to thinking about how we approach her pain relief and how we try and deal with her. So when the ambulance is going to see her, because 90% plus of patients will come to hospital with their broken hip, having been picked up by the ambulance service, when they see her, the ambulance staff know that she's in a lot of pain. They're going to give her some morphine. They may inject it, they may give it by mouth, but they're going to give her morphine because that's the sort of level of pain relief she needs. And that will allow them to get her up off the floor, get her into the ambulance, get her out of the ambulance onto a trolley in A&E. But that pain relief, morphine, the right dose of morphine will give you pain relief for a few hours, but it's not going to necessarily last the whole of the time that she's in A&E. And she's going to be moved again and again. She's going to be taken from the A&E department to the X-ray department and hopefully to the ward. And each of those movements, and every time that she needs a bedpan, she's going to have another exacerbation of her pain. And giving her repeated doses of morphine before each of those movements sounds a great idea, but if you add morphine to a previous dose and a previous dose, you rapidly start to get an accumulation of morphine, And we do see patients in whom a number of doses have been given and it's accumulated, and they're then very drowsy or respiratory depressed or confused as a result of it. So there's a real risk that amidst all the movements that we're imposing on somebody with a broken hip, we end up making her life very much more difficult with too much morphine. So how should we deal with that pain? Have you ever had a filling?
I haven't had a filling yet. Hopefully not for a while.
Okay, so I'm of a generation when we didn't have fluoride in toothpaste, and we had grandmothers who gave us barley sugar all the time. So I've had lots of fillings, and there's nothing would induce me to let my dentist give me a big filling, having given me a dose of morphine. I would want him to give me an injection to numb the area. And that's exactly the same sort of incident pain that you're seeing with somebody who's got a broken hip. It's the sharp nerve endings in the periosteum that are being tortured by a fracture as the two bits of bone grate against each other. That's the pain that she's going to be suffering, along with tension in the tissues because of the local hemorrhage into the tissues.
So what can we do to stop that sharp, acute pain?
Yeah. So what we do in the UK, and over the course of the last few years, pushed by the National Hip Fracture Database, we've moved to a situation where at least 3/4 of patients will be given a fascia iliac nerve block. So an injection of local anaesthetic into the groin in a way that permeates the necessary nerves and can numb at least some of the pain from a hip fracture. And that works for most people to some extent. And it will give them a numbing of the area, which is important. But it also is incredibly reassuring if you come in, you're in pain, you know it's horrible, and then somebody does something to show that this is controllable, there is light at the end of the tunnel. So it's a great way of relaxing people. But the key thing about it is it means we don't need to give her so much morphine. And that's fundamental to what we're trying to achieve for her. Because we know that we're applying morphine to a population of people, Grace, we know has got some cognitive impairment. Many people in her position will have renal impairment. Their ability to cope with morphine, and if you've got renal impairment, got problems with your kidneys, the metabolites, the bits the chemicals that morphine's broken down to, those just don't clear from the system effectively. So morphine can cause a lot of problem in people with renal failure, and a lot of problem in people who've got cognitive difficulties. So we don't want to give her unnecessary morphine. So using an injection as a way of minimizing how much morphine she needs is really important. You mentioned paracetamol as well. So giving her some paracetamol hopefully will take some of the background pain of the tension in the tissues, the bruising in the tissue, take some of that away for her and make life easier for her. And again, may reduce how much morphine we need to give her.
And if Grace is a cannula, would we just give her oral paracetamol, or would we give her IV paracetamol?
Yeah, so if we give her an intravenous injection of paracetamol, she's going to get the benefit of paracetamol very quickly. So it will feel more effective for her, but only transiently. So each time she gets an injection, it'll seem to help, but between times it's going to wash out more quickly than an oral dose will. So you're going to be having a bit more of a sawtooth pattern of pain relief with injected paracetamol than you will with oral. So give her an intravenous injection right at the beginning. That sounds entirely sensible. Gains her confidence, makes her feel better. But tying up nursing staff with repeatedly giving injections, repeatedly using glass bottles instead of 2 little tablets of paracetamol, that's not good for the planet, it's not good for your nursing staff time, it's not good for costs, and it's probably not good for Grace, because between injections her pain's going to come back perhaps more than it would have done if she were having oral paracetamol. So my patients are all on oral paracetamol throughout their time in hospital. The best treatment for pain is an operation, and that's the fundamental step. So we need to get on and do the operation. And once she's had an operation, she's not going to have 2 bits of bone grating against each other. Either they're screwed together or one of them is being thrown away and replaced with a metal hip. If she's got a hemiarthroplasty, half a hip replacement, or a full hip replacement, then we've taken away a lot of the nerve endings that are necessary. If she's had a fixation and a dynamic hip screw, there is an element with the dynamic hip screw of the two bits of bone grinding together as that slides together. So there will be some pain, but essentially the operation takes away a lot of the pain. However, she's going to come back from theatre with a different sort of pain. The day after her operation, she'll have a different pain from the one she came in with. She won't be having the instant pain, the same instant pain of bone against bone, but she will have more bruising, and the thigh area, the groin area, is going to feel sore on the day after surgery. So in the post-operative period, she's going to continue needing pain relief.
And how's that post-operative pain relief different to the pain relief she's been getting beforehand? I know you said she might have, for example, a dynamic hip screw, so would a nerve block be less effective in the post-operative period?
So repeatedly injecting people is challenging to do. It's not particularly pleasant for the patient. It's not the most dignified thing to have done, but it's not a practical option. But for most patients, the anaesthetist will think about doing some sort of regional analgesia, some sort of nerve block, before the patient comes back to the ward, because that way the patient comes back from the ward as their anaesthetic wears off. They feel things are better. The leg will feel less painful. They might get their first night's sleep since their fall. So it's a really useful way of avoiding filling her up with too much opiates on the night after theatre, and it means that she wakes up as fresh as possible the next morning when she's got to take the challenge of trying to get up and get moving again. How do we give her analgesia on the day after theatre? The crucial thing is that there isn't an answer to that question. There's an individual, and what we need to do on the morning after theatre, or what we need to anticipate before the morning after theatre, is what's Grace as an individual going to need as pain relief. And we have a huge advantage by that stage that we can look at what she's been having in the time she was in casualty, the time she was on the ward waiting for theatre. We can look at how much morphine she's been needing, and we can look at how she's responded to it, what dose she's having, how often she's needing it. And that allows us to make an individualised judgment as to how much morphine she might need. So we might be giving her 5 milligrams of morphine and showing that that's effective for her, but for some larger people, younger people, 5 milligrams won't be enough. For some of the frailer patients, 5 milligrams may be more than they can cope with. For people with renal and brain problems, you might be wanting to think about oxycodone, which has got no particular advantage. It's no stronger than morphine, but it is less likely to cause confusion in people with renal impairment. But we'll have a sense of what sort of dose is likely to suit her, and we should be writing that up. We should be writing it up so that when we come in the morning and the physios come in the morning to see her on the morning after her operation, she's already had the dose that we think is going to be about right to allow her to start moving around.
So are you suggesting potentially a personalised plan that allows patients to get their regular morphine or oxycodone dose based on essentially their regular doses they've been taking throughout the day for the amount of pain that they feel is necessary?
Yes. So we know her because she's not new to us. She's not somebody we saw her before operation, and one of the things we're doing in preparing her for operation is to get her onto the right sort of dose of drug. But we don't necessarily need to treat her all the way through the day. She's going to be sore. We need her to have had enough morphine to allow her to get up first thing in the morning, but we also need her to be not over-treated at parts of the day when she's not having pain. So we would write up a regular dose of morphine at breakfast and lunchtime, but we wouldn't then be giving her additional doses in the evening routinely. They would be on the as-needed PRN side of the drug chart. So if she's uncomfortable overnight, then it's possible to give her something. But if we're not routinely giving her pain relief when she's lying still in bed in the evening, then it gives her brain and her bowel a chance to keep moving and working, and that would be more effective for her. So trying to tailor her timetable of painkiller. And then on my ward round, when we go and see her on the morning after theatre and the next day and the next day, I can ask her whether she's in pain, and she's going to say no, because she's sitting still or lying still. It's not going to hurt if she's not moving. So what I need to do is to move her leg, and to see whether she can move her leg comfortably enough for her and the therapists to feel that they're able to get her up and get her on with rehabilitation. So the individualization of her treatment means looking at how she's coped with what she's been having, adjusting the doses up and down, or moving to oxycodone if she's becoming confused. But moving her leg, and it's looking for pain relief, pain control while moved, that's fundamental to this. So it's getting somebody to do a pain score of her when she's quietly asleep, having had her breakfast and is not moving in bed, is meaningless. You've got to be able to do this and work with her, and to be able to assess how well, particularly people who are confused, how well controlled their pain is. You've got to move the leg to be able to try and do that. So we would have a routine of giving breakfast and lunchtime doses, adjusting those, and then as she gets stronger and as the prospect of climbing a ladder becomes more realistic, towards the point of discharge, we would be thinking about moving her down the analgesic ladder and getting her onto possibly codeine or just paracetamol in anticipation of discharge. And that's the sort of regime that we would take. We don't use any long-acting opiates at all. If you put her on a long-acting morphine dose, you're giving her morphine 24 hours a day, even though she's not needing it half the time. It's also much less flexible. It takes time for it to get up to its peak effectiveness. It's much more difficult to know when and whether you're making the right decisions in weaning people off it. And the MHRA, the regulators in the UK, have been very clear that we shouldn't be using long-acting opiates in these patients. So the long-acting oxycodone and morphine is something we never use at all. There is one long-acting formulation of an opioid, which is buprenorphine, which comes as a patch, and you can put a patch on that will last for a week. And that's a very attractive idea. It avoids lots of controlled drug rounds, which would be an issue with oxycodone repeated doses. But the use of buprenorphine has, again, the inflexibility of a long-acting drug. But it is very useful in people whose swallowing is such that they can't take tablets by mouth, or who have a disinclination to take their medication. So somebody who's confused because they're in pain, having a buprenorphine patch on may be a way of trying to control their distress and treat their delirium. I tend to just put a buprenorphine patch on for that sort of individual as a single event, not as a we'll do this every week. Just put a single patch on and then let it wear off over the course of 10 days or so as the pain settles, because the broken hip will not be anything like as painful next week, and weaning people off is really important.
And what about other co-analgesics that you might use in this situation, Prof. Johansson?
Yeah, well, I don't. I think it's really helpful for the staff, the nurses, the therapists on the ward to all feel comfortable that they understand the painkillers that we're using. So we try to keep a really limited list of drugs that they're familiar with, we're familiar with, and everybody feels confident in. So trying to chop and change and try different things is much less sensible than adjusting doses of drugs with which everybody's familiar. You could use a non-steroid or anti-inflammatory for orthopaedic pain, but it's very rare that you really know what somebody's gastrointestinal history is, whether they've had problems with GI bleeding in the past. For many of our patients, you can't get a reliable history, and so there's a real risk associated with those. this is a group of patients with a lot of renal impairment who are going to have hypotensive episodes, many of them around the time of theatre, so acute kidney injury can be a real issue. And surgeons are nervous that non-steroidals may have an impact on fracture healing, so we essentially never give non-steroidals. Then the antidepressants, we spend much of our time on the ward questioning whether people should be on anticholinergic antidepressant drugs as part of our falls management. So starting an antidepressant such as low-dose amitriptyline is an extremely unattractive thing. It's not going to work quickly. The patient's pain is going to have gone away before it really has a chance to bite. And the same is true for the gabapentinoids. Things like gabapentin or pregabalin don't work as analgesics. They have to build up in the nerve for 2 weeks before they have any analgesic benefit. They do muck around with the GABA system in the brain and can have an anxiolytic benefit, but mucking around with the chemistry of older people's brains is a perilous thing to be trying to undertake. So again, I don't think those are really very relevant. So we really are on nerve blocks, paracetamol, morphine, or oxycodone. Nearly all of my patients will be treated just with that limited black bag of drugs that everybody on the ward is familiar with.
Oh, well, that's a very good brief overview of pain management in hip fracture patients, Prof. Johansson, and very relevant to the whole MDT, I hope. Thank you all for listening, and any other topics you would like us to cover, please let us know. Thank you very much. Bye.